The important question, cryopreservation of a few testicular or ejaculated sperm, is it effective? So the answer to this question is yes, it is effective. In the coming 19 minutes, I will try to convince you that it is effective. I hope that all of you will agree with me that the routine sperm freezing of a donor sperm is inappropriate for freezing small number of spermatozoa due to the large volume and loss of spermatozoa after thawing. I hope that no argue about this statement. The next question is why? Why do you have to freeze small number of spermatozoa after micro-tesse or tesse that you are doing? Because fertility preservation is a mandatory process or thing that you have to think about it. Multiple testicular biopsies is with side effects, and I hope that all of you who are sitting in this room will agree that multiple tesse or sperm biopsy is with high side effects, and you have to do everything to prevent from this procedure. And again, about this statement, I hope no argue. Another aspect in why do you have to think about freezing small number of spermatozoa. You did a microtesse with retrieval of spermatozoa. You had a successful treatment. The female conceived, you did an ICSI, you transfer embryos, everything was perfect. The leftover tissue, you putting in a freezing. Now your patient comes again and he desires for another child. You have no idea what did you freeze. You hope that as you find in the first treatment, you will find in the next treatment what you freeze. But sometimes you have unpleasant surprise that you don't find spermatozoa or you don't find enough spermatozoa to the eggs that you retrieved. And again, I hope you understand and no argue about it, that your patient desire a precise information regarding what are the left spermatozoa, how many spermatozoa is left after your first micro-tesse. So, two statements that I hope no one in this room will argue about it. Now, if you want to plan a device for freezing spermatozoa, you have to stand with 4 criteria. You have to think about 4 criteria that your device will be useful with good clinical results. At least 90% of recovery rate after thawing, motile or viable spermatozoa after thawing, and I didn't write here the percentage of the spermatozoa, and we'll discuss about it. An acceptable fertilization rate of approximately 40%, and IVF, it's a teamwork. You have doctors that are doing the ovum pickup, but you have a very important staff, which is called the embryologist. And if you not have a cooperation between the doctors and the embryologists, you have no successful technique. Therefore, when you want to desire a device that will be for clinical use, you have to think about your partner in the lab. and it has to be easy and simple to accomplish. And I put it in red, in a green line, because it's important as your protocol for ovum pickup. No cooperation, no successful cryopreservation. Now, according to the ASRM, there are two definitions that we have to distinguish between them. And first of all is cryptospermia, when spermatozoa are absent from fresh preparation but are always observed if you are doing a centrifugation. In virtual azoospermia means that occasionally you can find spermatozoa, and sometimes you don't find spermatozoa and you have surprises in the day of ovum pickup. Before we'll go to discussion, the cryopreservation of few spermatozoa, we have to go back to the history. Actually, the first thesis was published in 1995 by DeVoy. It's almost 30 years, something like that. 14 years later, the issue of fertility preservation raised up. And doctors started to think, what are you doing with the left spermatozoa after your TC? And this review in the Human Reproduction was published 14 years later, summarizing the different technique for freezing small number of spermatozoa. As you can see in the slide, it was more research than clinical use, because if you look in the site, you see that most of the technique, fertilization rate was not published. So how can you use a technique when you don't publish your fertilization rate? And actually, the conclusion of the article is that the current evidence is not sufficient to support the use of one technology over the other, and we need further studies and devices to establish for freezing small numbers of spermatozoa. Before we're dealing with the freezing small numbers of spermatozoa, I think that we have to ask a question. Is small numbers of spermatozoa is effective, or is it you can for clinical use, or it's better that if you have 12 spermatozoa in the ejaculate, 20 spermatozoa in the ejaculate, what is better? To offer your patient a TC or micro-TC, or use these few spermatozoa? To answer this question regarding few spermatozoa in the ejaculate, what you should offer your patient? We publish an article in Fertility Sterility, and we compare fertility outcomes after extended search for ejaculate spermatozoa in men with virtual azoospermia. And since we didn't have precise guidelines, what should you do with your patient with virtual azoospermia who have few spermatozoa in the ejaculate? And every doctor in our team can offer his patient according to what his belief. Some of us believe that micro-TESA is the preferred method of treatment, and some of us thought that still micro-TESA is an invasive procedure, and in medicine, you have to do everything that you can before you go to an invasive procedure with possibly complication. So we had 102 patients who went to micro-TESA, and 140 patients that went to extended sperm research. From the 140% who went to extended sperm research, spermatozoa was found in 91 patients, And in the day of ovum pickup, from those 91 in 71 patients, we were able to find spermatozoa in the day of ovum pickup. So you can see that it was really patient with virtual azoospermia, few spermatozoa in the ejaculate. And we compared the two groups of ejaculate and microtessa, no difference in the number of eggs that retrieved, in the levels of FSH and LHA before the treatment. And what is important is to compare your fertility outcome between the group who went to microtessa and the group of ejaculate. And according to the ESHRE recommendation that a successful ART treatment is the take-home baby rate and not pregnancy rate. So you can see that there is no difference in the take-home baby rate between extended sperm search in the ejaculate and microtessa. So if you conclude, first of all, if you have a semen analysis with no spermatozoa, don't give up. Go to extended sperm search, and you were able to find spermatozoa in the ejaculate. And these spermatozoa in the ejaculate, you can use them for injection to the egg, and you can achieve pregnancy and fertilization rate. We continue with our policy of extended sperm research, and again, we are able to find and around 50% of our patients that were diagnosed as azoospermic in routine semen analysis. If we are doing an expand sperm research, we are able to find in 50% of them spermatozoa in the ejaculate. In the Journal of Urology, it was really a great issue. They did an extended sperm research and microfreezing for fertility preservation after long-term hormone therapy in transgender women. It was published in this year in the Journal of Andrology. They had 3 transgender women after long-standing hormone therapy, and I mark you, they were able to find few spermatozoa, don't know how to say it in the ejaculate, but after extended sperm research, here you can see that in one patient they freeze 278 spermatozoa. In the other patient, they freezed 8 spermatozoa, and we are waiting now for the clinical outcome of this freezing in transgender women. So I can say that we can conclude that extended sperm search in the ejaculate is an efficient method for the ICSI procedure. Now, for the next question is it efficient for freezing a small number of spermatozoa? I went through the literature and I did a summary for the technique of freezing from 1997 till 2018, and I marked the milestones in freezing small number of spermatozoa. The first one, after the publishing of De Vroy in 1995, in 1997, Cohen et al. Published the technique of freezing small number of spermatozoa in empty zone. Since This is a biological material. You are not allowed to do it anymore. Between 1997 to 2012, there was another technique. I wrote you the important technique. It was the cryoloop, XC pipette, and the agrosome technique. That the agrosome, you can see, it's mimicking the zona pellucida. But this technique didn't raise up for huge clinical use. I want to go to the next technique that was published in 2012, and I think that this is a very important publishing. In 2012, Yuji Endo who was the first one who put the word vitrification in freezing spermatozoa. Vitrification you use in embryos, you use in eggs, but he was the first one that used the word vitrification in freezing spermatozoa. You can see the volume that the spermatozoa were freezing. It was for milliliter. We went to microliter. We switch. You can see that the volume that the spermatozoa were freeze was 0.5, 1 microliter, and 3.5 microliter. And you can see that, first of all, recovery rate was wonderful, 100%. He freeze 50 spermatozoa, he found 50 spermatozoa. No loss of spermatozoa after thawing. What is important to look at is that there is a relation between the volume that you freezed and your motility. And you can see when you freeze with 0.5, you have just 38% of motility rate. And when you freeze with 1 microliter, you have 64% of motility. We tried it as well, and we got the same results. I think that is a physical problem. When you freeze with a very small volume, you have physical powers on the spermatozoa that decrease your motility rate after thawing. Therefore, we will freeze in a volume of around 1 microliter. This is the device, the cell sleeper, that was published by Yuji Endo. And we discussed this device in our article. The idea is good. The device is not good. And I will explain you why. Because you can see that in the cell sleeper you have walls. When you use the micro manipulator and you want to pick up the spermatozoa, you have a problem with the walls. 1. 2, you can see this is unstable. When you put it on the dish, it's like a boat. It moves. Therefore, the idea is good, the device less. Again, I wrote you the 4 criteria that you have to use before you develop an optimal device for freezing spermatozoa. Easy and simple to accomplish. And cell sleeper is not easy to use. We published in the Human Reproduction in 2018 a novel solution for freezing small numbers of spermatozoa using the sperm vitrification device. And this is our device for freezing small numbers of spermatozoa. It is able for cryopreservation of very low numbers of spermatozoa, aims to maximize the fertility preservation for males. And this is a table from the human reproduction, and I want to explain you this table. Before we started to use the sperm vitrification device, we compared it to the tube for the regular freezing in a tube. When you freeze in a tube, the motility rate that you have after thawing, it's not a motility rate, it's survival rate. And I will try to explain it. You have a motility rate in the original sample, and after thawing, you have another motility rate. So you have to divide the motility rate after thawing divided to original motility rate before thawing, double it in 100, and you have the survival rate. And you have to compare the survival rate in a tube to thawing after you freeze in a sperm VD, because on sperm VD you put only motile sperm. This is the right way to compare the two methods. We never said that freezing few numbers of spermatozoa in sperm VD, you have a higher rate of motility rate after thawing. We said always that the motility rate can be the same, but the recovery rate is differently. You can recover of almost 100% of the spermatozoa that you freezed. This is a table from the human reproduction that was published, and I want that you look in the first line that was marked in red. All of you know the sentence, the beginner's luck, and really, when we started our project with freezing small numbers of spermatozoa, we had a beginner's luck. Patient number 1, you can see the details of the male, the female. However, he had only 2 spermatozoa that was found in his ejaculate. In the day of ovum pickup, he gave another first sample, and we didn't find spermatozoa. Therefore, we retrieved almost 20 eggs from his wife. She was young, 22 years old, and we inject only 2 spermatozoa that were found after thawing. These 2 spermatozoa gave us a twin pregnancy. This was our beginning lucks, and this gave us the efforts to continue with our research towing cryopreservation of few spermatozoa. Here you have the characteristic of all the 44 patients of using the sperm VD. We did mistakes, and I want to show you an article that we published with our mistake. When you freeze a spermatozoa, you use a cryoprotectant that you use it when you freeze the spermatozoa. You have to pull out your spermatozoa from the cryoprotectant as soon as possible. And if you leave the spermatozoa in the cryoprotectant, as you leave it more time, your motility will decrease. Therefore, we publish the sentence that when you are doing vitrification with spermatozoa, please remember quick in, quick out. As soon as possible, retrieve your spermatozoa out from the cryoprotectant. So, okay, sperm VD is an efficient and simple carrier that optimizes the protocol of freezing small number of spermatozoa. You have a high recovery rate of almost 96%. We have made another progress, as I told you, that it should be an easy to accomplish procedure. And for the embryologists, we create a groove in the dish that the sperm VD will be stable and easy for use with the micromanipulator. And to conclude, that microfreezing of small number of spermatozoa is an efficient method if the optimal device is used. So I hope that I convince you regarding the organizing committee question, is it effective? The answer is yes. It is effective to use to freeze small numbers of spermatozoa, but you have to choose the optimal device for freezing small numbers of spermatozoa. Thank you for your attention.